Well, I like doing these segments, and hopefully everybody else does too. But I think that they give you just a little bit of it's a little something interesting, a little something that you may not have heard before, but stuff that may be pertinent and stuff we can hopefully learn from in terms of the care of patients that we do nowadays. So what we do in these segments is take a historical event, tell you a little bit of a story about it, and then approach it as if we had it sometimes in the time period, sometimes in the now. And today we'll probably just take it in the form of the now. But as expert opinion on the matter, we're happy to welcome again Professor David Pfeiffer from Eastern Kentucky University, the program director for their paramedic program, and essentially the soul of some of the other stuff we've got going on, such as the Red Star Wilderness EMS, and good guy to have around to comment on some of this stuff.
So, I really consider myself the soul of EMS in general. Maybe a little bit grandiose, but anybody who wants to argue with me about that is welcome to. So.
And he's super humble. All right. So I want to tell you a story. And this is a story about stuff that, I usually pick things that I kind of have an interest in. And so this is about something that happened near me. I was, I was a kid growing up in the 80s and early 90s in Cincinnati, in the Cincinnati area. And this was something that I remember distinctly happening. I wasn't so much the news follower that I am now, but at the time, I do distinctly remember the evening that this occurred, and it stuck with me all this time. So it's nice to be able to kind of talk about it and review it now. This is a recent history, and I do want to just kind of say before we get into any of that this is in no way, as some of these people may be around still. Some of the folks that dealt with this incident, those folks may be around, and this is essentially, other than the story, a hypothetical. How might you approach this kind of stuff? Not a criticism of anybody or a should have done or something like that by any means at all. This is simply taking the case that is now about a 30-year-old EMS call, and what could you do about it? How might we approach it if at least we're in the comfort of our respective offices, and some stuff that we might be able to learn from what actually happened. So that said, I'll get out of the way and I'll tell you the story. All right. We're titling this one A Bad Day at Kings Island. So Kings Island opened in 1972. It's a theme park in Mason, Ohio. That's northern Cincinnati, about 20 miles north of kind of the city center, if you're not familiar with the local geography. But if you're from anywhere in the Ohio, Kentucky, Indiana region, you've probably heard of Kings Island, and there's a good chance that you've driven past it before. It was a combination pleasure park and thrill rides. So not only just roller coasters, but also kind of fun things to do. As I said, kind of 20 miles or so north of Cincinnati itself, which is down the lower left-hand corner, up along Interstate 71. You see it when you drive past. If you're going from, say, Columbus to any other place and you go down 71, you will note this gigantic theme park with the Eiffel Tower out in front of it. It was built to replace the iconic Cincinnati Coney Island, which is down, if you see that heart down next to the word Cincinnati, down on the Ohio River, and had been in place forever, but it was on the Ohio River, and so it flooded. And in the 1960s, one particularly bad flood put Coney Island under approximately 14 feet of water. And at that point, the developers said, it is time to move this theme park out of this river valley and off to someplace else. And the place they picked was Mason. So not only was a theme park, it was a nice place to be. Not only designed with roller coasters and rides, but also some themed areas where you could go and have a nice time. There was a Bavarian-themed Oktoberfest area where there was a beer hall and live music. There were live music shows. There was a kids' land that was Hanna-Barbera themed at the time, having been developed by Taft Communication, who owned Hanna-Barbera. So that's Yogi Bear and Flintstones and those guys. And of course, to be the most recognizable part that it possibly could be, a 1/3 scale Eiffel Tower was built at the entrance of the park along the main international street there. It is something to behold. There was also stuff that went on, would host a number of dramatic events that would cause it to rise to prominence in the 1970s and 80s. Was on a number of TV shows like The Partridge Family and Brady Bunch Special. There was Evel Knievel, which you see here. His record-breaking jump over 14 school buses occurred in the parking lot at Kings Island. And then Carl Walenda's 1,600-foot tightrope walk, which was, again, at the time, record-breaking, from the Eiffel Tower to another pole in the city, or in the park itself. And not only that, but the place had a zoo. There was a wild animal safari where you could go on a monorail and see lions, tigers, giraffes, etc., out in sort of their quote unquote natural habitat, if they had a natural habitat in central Ohio. It also had a number of record-breaking rides, which I just bring up. There was the Bat, the first modern inverted roller coaster, the Beast, which you see here, the world's longest, fastest wooden coaster, and I believe highest wooden coaster at the time, which is still a thing to behold. And the Vortex, the coaster with the world's most loops, at least at the time being, which was 6, which recently closed down as well. Kings Island had its share of problems over the years. None too awful much, but things that happen when you have a bunch of people in the same place, and the imbibation of alcohol as well added to it. Along the way, 2 zookeepers were mauled in separate events by the big cats at the safari park. There was a teenager that was killed when he jumped onto the top of an elevator in the Eiffel Tower. Despite rumors, no one was ever actually killed on the Bat or on any of the other roller coasters up until that point. It was marred with problems, and a couple of the rides had issues that caused them, even though they were iconic and interesting, to shut down early. But nobody actually was killed on any of the rides other than the Eiffel Tower at that point. At some point, someone had dove into the large fountain at the front of the park. But again, nobody that was actually injured on one of the attractions otherwise when it was functioning and they were in their place. That changed on June 9th, 1991. It was a Sunday evening, and it was warm, and a number of things were happening at one time. About 8:30 or so, a 22-year-old man and his friend were walking across the bridge in the Oktoberfest area, which you see at least cartooned out here. They were coming and finishing the day's events at their company picnic. They'd had a little bit to drink during the day, but by no means seemed completely intoxicated, and were just getting ready to finish up the evening. You could see that things were getting dusky, everything was cooling off, and night was setting. They were walking across this bridge to finish up when he reached down over the rail to splash water from a fountain at his friend. He suddenly screamed and fell into the water over the railing and remains unconscious. Unbeknownst to him and to the park, a water aerator pump, which had been installed to cut down on algae and growth in the pond itself, was short-circuiting, and it seemed to be intermittently energizing the pond. For some reason, the fish in the pond don't seem to be affected by this. There were ground fault circuit interrupters available, but they weren't installed, and the breaker, for whatever reason, was not tripping. So his friend, upon seeing him scream and fall into the lake, immediately jumps in to rescue him. He also receives a shock and falls unconscious into the water. A 20-year-old security guard who happened to be walking nearby heard the screaming and observed the 2 men in the water and also jumped in, similarly receiving a shock and falling unconscious under the water. This is a stock picture, not the actual photo of the incident, but to give you an idea of perspective and where it happened. Passers-by witnessed the scene, and now concerned that 3 men had all gone into the water and all seemed unconscious for no apparent reason, became concerned and did not actually enter the water themselves. But one passerby was able to use a garbage can lid to hook the victim's shoulders and pull 2 of them out onto the bank. He then grabbed another patron by the ankles, and they reached in and grabbed the now fully submerged first man who went into the water. A passing nurse noted the scene and directed folks to start CPR on the 3 victims. The accident occurred at 8:48 in the evening. At 8:51 was the first call to the Mason Fire Department, and at 9:02 the first unit arrived. They would commence resuscitative efforts and call for a helicopter. The first man in was actually the first man who left the scene in an ambulance taken to Bethesda North Hospital. At 9:25, UC Air Care lands and then departs with both of the remaining patients who are still under active resuscitation at this point and head to UC Medical Center. Unfortunately, shortly after arrival at the hospital, both patients would be pronounced dead. Meanwhile, as Air Care is lifting off from the parking lot, on the other end of the park, 3 friends from a local truck driving school are finishing their day in the park. They'd ridden almost every ride and had a generally good time, a little bit of beer here and there, but by no means seemed markedly intoxicated. 32-year-old Candy Taylor watched from the base of the ride as 2 of her friends climbed aboard a ride called the Flight Commander. Again, this is about 500 yards from the other accident scene, so they were probably not aware of what was going on, or at least it didn't stop or slow down the rest of the park's action. The Flight Commander was a spinning ride that, looked like this. Basically, you climbed into a 2-person pod, and the thing spun around and went about 60 feet up in the air. By means of a joystick in between the 2 seats in the pod, you could do a barrel roll or go up or down and have at least some limited control of this. But the entire ride would turn itself and spin on sort of an axial rotation. And I said, do barrel rolls and stunts. The pods themselves looked like that, and they did have shoulder restraints and lap restraints. Taylor watched her friends ride from the ground as she was finishing a beer. At about the same time Air Care was lifting off, she got on board the Flight Commander Pod 4. She sat in an inner seat, and while you're normally paired with somebody, she in fact rode the ride alone, and there was no one occupying the seat next to her, the outboard seat. The lap restraint and the shoulders were checked and all seemed to be in working order, and the ride took off. The ride seemed to be operating normally, went about its usual cycle. At some point, witnesses and her friends watching from the ground noted that Taylor seemed to slide into the adjacent seat, and at that point, the pod began a barrel roll. It completed 1 roll, and as it went into the second, midway through it, Taylor was ejected as the pod was about 60 feet in the air. She fell about 30 feet away from the ride on this grassy hill. When her friends reached her, she was still breathing, but she was markedly unconscious and she seemed terribly injured. They called for EMS, who were about 200 yards away, still at the Oktoberfest scene. They requested a second helicopter and attended to the patient, who was then taken to Miami Valley Hospital, which is in Dayton, about 40 miles away. She arrived there at 10:33 and was pronounced dead at 10:34. The cause of the accident was determined to be most likely, and it's always hard to tell, that while the shoulder and lap restraints were sufficient to keep someone who may have been unconscious or limp in their seat, provided there was somebody in the seat next to them, if you did become unconscious and there was nobody occupying the seat next to you, you could, as you see this guy, is an accident investigator demonstrating, slide out hips first and then leave the shoulder restraint as well. The ride would reopen with modifications to prevent this from happening again. And what's believed to have happened is that for some reason, Miss Taylor lost consciousness. When she slid over, her leg, as you see this gentleman's doing, hit the control stick, which caused the pod to go into the barrel roll and then slid out, and the centrifugal force ejected her from the ride itself. Now, it is noting that Taylor was intoxicated. Her blood alcohol level was 0.3, which is about like 3.5 times the quote unquote legal limit for driving. But we all have seen somebody that is intoxicated to that extent, and they tend to not pass out. So I think judgment that the patient, that this is her fault because she was intoxicated, is probably miswarranted. And even if that was the case, the ride still should have kept a person in place, even if they were unconscious or had suffered a syncopal episode. The ride would be reopened with safety features, a bump in the middle, better seat restraints, and would go on to operate for about another 10 years or so before it was finally closed down. That's the story. So, David, let's say that you're the first responding crew to this incident. Others are about 5 minutes behind you. You've been toned out for an unresponsive male patient, possibly drowned. And on arrival, as you're walking over, you find 3 men unconscious, wet, and receiving bystander CPR. They've been down for about 10 minutes at this point, and they were in the pond, which is warm, for about 5 minutes before they pulled out. So as you're walking up to the scene, what are you thinking? What's your considerations? What are you going to tell anybody that's with you at the time?
So the first thing I was thinking about while you were talking about all this is, as a paramedic, I basically do the same thing as a doctor, but at 80 miles an hour. So I started trying to think of the math of how fast I would have been going on a roller coaster or a similar ride. And I'm not a numbers guy or a scientist. So suffice to say that I would have been going really fast. And I just think that's important for you as an EMS physician to appreciate about me as a paramedic. So that being said, my considerations, I think, would be, obviously, I think it's obvious to everybody we have a mass casualty situation. So you are, definitely want to be thinking about, just based on the nature of the dispatch, about, calling additional resources and starting to think about your kind of command structure and, incident management principles. So declaring an MCI, setting up command, some of those kind of basic things that sometimes get short shrift in our training courses and that we all kind of fall asleep in, when we're trying to do our ICS refreshers. This stuff actually becomes pretty important in a situation like this because of the X factors and the unknowns, and you're in the middle of a park and it's busy and, there's a lot to coordinate. So that's certainly something to consider, and if you're well practiced in that stuff, then it should sort of be second nature for your agency or your department to go through certain steps once that MCI declaration is made and once command's established. So then I'm certainly, going to be turning my attention to making sure that, starting to think about the, kind of differential diagnosis or, potentials of why we have these 3 people who seem to be pulled out of the water all unconscious. So, I think that this is the sort of thing that just kind of comes with probably equal parts experience and critical thinking about, like, what is the common denominator? So when you're evaluating, you have multiple patients who sort of seem to be affected by the same etiology as far as we know at this point. They're all wet, they're all unconscious. You sort of start thinking about, it's like, okay, what are the environmental factors, or what are some mechanisms of injury that could have resulted in this happening to 3 people? And, are those threats to me? Is it an ongoing threat? Is it a dynamic kind of a threat? So, if you're kind of on the front end of the experience curve, you might not be used to thinking in those patterns yet. But if you have kind of been doing this for a little while, you ought to be able to key up on the fact that, we have some common denominators between all these people. So I'd be thinking about those kind of safety considerations and etiologies. And I think probably near the top of my list would be maybe people slipping off a bridge, somehow entering the water accidentally, and potentially there is some sort of, drowning maybe is the mechanism for all 3 of them, in of itself. But then I also want to be thinking about, was there a hazard in the water or a hazard that caused them to fall into the water altogether? And then I think it's time to start thinking, about basically triage and treatment. So if it's kind of just me, I'm the first arriving crew, so maybe me and a partner. We have 3 patients, there's 2 of us. We probably need to start making some decisions about, do we get some other people involved? So maybe there's security officers on the scene who have some basic first aid training or CPR that we can put to work. Maybe there are bystanders, and we could say, does anybody have medical training who's willing to get involved and help out? We sort of have to divide and conquer. The interesting thing about this is that if we are suspecting electrocution, which is something that is, there are actually several case studies about this. So it's not like the inside scoop to be thinking electrocution. There's actually a lot of cases where this very same thing has happened kind of throughout America. And this actually reminds me of one that happened strikes a little bit closer to home for me, because I used to work in Washington, D.C., and there's a huge convention center basically on the Maryland side of the Potomac River called the Gaylord Convention Center at National Harbor. And there was a very similar thing that happened where there was electrocution current that had there was like a railing, like a metal railing that was energized, and a little kid touched it and got electrocuted. And then somebody else came to help her and brushed up against that railing and got electrocuted. And then a security officer came and tried to help them and got electrocuted. So whenever you are in these sort of mass gathering situations, amusement parks, hotels, things of that nature, festivals, and you have a lot of people like down and you don't really know why, I'm going to start thinking about electrocution. That's one of those things that could affect lots of people at once. So I'm going to be thinking in those ways. And if that's the case, if that is what caused their cardiac arrest, we have a very interesting triage challenge, because generally when we're talking about electrical causes of cardiac arrest, be it a lightning strike or electrocution, you would employ a methodology known as kind of reverse triage, where you don't just skip over the seemingly dead. You actually try to resuscitate them and try to get an AD there, because they're very, typically respond very well to defibrillation, right? So that's a big if. That's if it's an electrical, pathology that caused this. So those are some of the things I'm thinking about right now. It's a lot. I got a lot on my mind. I'm still trying to work out the math of how fast I was going on the roller coaster. But to answer your initial question about what are my initial thoughts, there's a lot to unpack. And I think everybody on this call is probably a relatively experienced provider. And we know that we think about a lot of these things almost not subconsciously necessarily, but we are used to thinking about a lot of things at once and doing a scene survey, collecting a lot of information, starting to talk to bystanders, and synthesizing a lot of information really rapidly. So even though it sounds like a lot, it's stuff that probably you have a pretty good grip on doing on an almost intuitive system one thinking kind of a level.
Dig it. Now, one question I had as I kind of was thinking about the same thing, and you mentioned it. Do you think this scene is safe? Now, you're just to give you perspective, this is the area here where this is where the bridge is. They pulled the guys out onto this like kind of bank over here. Would you consider this scene safe? Would you go ahead and approach it?
Yeah, I mean, I'd probably go ahead and approach it. I mean, the idea of scene safety, I think, is not as discrete or as linear as we are certainly taught to understand in like initial training courses. And we all know that. And we all know that scene safety is dynamic and an ever-present concern. And in a place like an amusement park, there's probably, a limitless list of potential safety issues. But I think that there's some clues that we can look around at, right? So although the people who are wet are unconscious, are the surrounding, rest of the bystanders who are not wet, do they seem to be in distress? So again, there's sort of like a rapid visual, who's okay and who's not, is anybody else in distress here that we can proceed with? And then we just need to sort of be, cognizant of the fact that there may be some unknown hazards. So, I think that it's, the question is not necessarily is the scene safe or unsafe in my mind. It's, is it, maybe a better way of thinking about it would be how pronounced are the inherent safety hazards to me? So I would proceed probably, but I would do so very, very carefully. And there's probably some more information that I need to collect before I just kind of, kneel down and get straight to work. So again, we're talking about maybe a matter of seconds of asking, does anybody know what happened? Did anybody see what happened? Is anybody else feeling unwell? Are there any other patients anybody knows about? And if we can ask some of those questions and basically get a quick story about like, these 3 people went into the water, they got in trouble, we pulled them out of the water, it's probably safe to go ahead and kind of start operating there.
Yeah, I had the same thought essentially, in that you see, there are people touching them that are doing CPR and don't appear to be dying themselves. But the one kind of hazard that I think of that we don't usually, that kind of slips our minds, I think, is once you get into it, once you start kind of walking around this person or somebody, makes a move to try to lift this guy onto put this guy onto a long spine board or something, if you come in contact with that water that you're on the edge of, that's potentially a pretty significant hazard and killed these guys anyway. So yeah, I am with you, with caution that you may be able to approach this guy, but I'm a little nervous about whatever it was that caused them to go down, whether
Now,
it was toxic gas or electricity.
personally, whenever I go into Ohio, I'm nervous and I get kind of freaked. And so, my index of suspicion just overall is like super elevated. And so, but that's a gift, right? Fear is a gift. So I'm terrified of Ohio, and that's going to actually keep me safer because I'm going to be a little bit more discerning.
There's a lot to be said for that. All right, and working our way down the standard thing. We identified there were 3 patients, and you mentioned before the reverse triage that you might do in cases of like electrocution or lightning strike. In terms of was just the drowning component, you just find these guys wet, let's say, and you didn't really know about the electrical component, maybe you had a suspicion. You got 3 patients, and you see people getting chest compressions you see 3 people getting chest compressions from bystanders, but there's only, like you said, 2 of you. You got more people coming, but it's going to take them a couple minutes to get there. Where are you going to put your attention first now that you've got these 3 unconscious, not breathing patients all getting CPR?
So, this is pretty tricky, right? Because like at this point, kind of everything else being equal, they all have a theoretically equal chance of survivability and chance of ROSC and all that kind of stuff. So I would be looking to see if the quality of CPR being performed is adequate, and if there's any other complicating factors, going on with those things. If there's airways that need to be cleared or positioned or something like that, do we have 3 AEDs? If we don't, can we be thinking about some, somewhat novel things like if I have multiple sets of pads in my LifePak 15, can I be putting pads on everybody and scurrying around and plugging and unplugging, to do, manual rhythm interpretations and defibrillate on a cycle, and, just some really kind of like high end, like very kind of advanced, almost crisis standards of care, kinds of approaches. So that's what I'd be thinking of, because right now we have these like 3 patients. They're, I think, basically, if I'm tracking the information correctly, basically of like similar age. All
early 20s.
Yeah, similar etiology. So, nothing stand out. Nobody has like some sort of like grievous head wound or, something like that. So it seems survivable. So I'd be looking at almost my partner and I turning into almost more of like code commanders. And if CPR quality, if we can be coaching people into just doing high quality chest compressions and trying as best we can to defibrillate in a timely fashion, that's probably where I'm going to keep my attention right now. Because I don't really think there's a whole lot more we can do than, without more help, right? So again, like if there's vomit in somebody's airway or, just what airway, occlusion issues or whatever, and the civilians don't know how to handle that or don't know how to, don't know what to do, we can probably be stepping in on those ways. And then if nothing else, I would probably just be prioritizing, high quality chest compressions to try to keep perfusion going as best we can until more AEDs, more cardiac monitors get there. And I'd also be making sure that I communicate, via radio to responding units to make sure that they come in ready to work a full code with all the necessary equipment ×3.
Very good. One other thought: when you're doing these treatments, as you're telling your next arriving units to come in, this is this seems to be a drowning, as far as we know at this point. We're early into it. Would that change any kind of treatment consideration that you'd be thinking about in terms of your cardiac arrest management? Or are you just going to do as much as, just like you would grandma on the floor?
Yeah. So in general, the thinking is oxygenation and ventilation become much higher priorities much earlier in the code with causes that are, kind of known asphyxia issues, and drowning is on that list. There's quite a bit of controversy out there, even amongst, true subject matter experts on this, about how we're supposed to tweak our process with this. So there are some authorities who advocate doing early ventilations and oxygenation. There are others who say, still fundamentally you gotta, start with chest compressions. There's people who talk about giving like 5 initial breaths rather than, the standard kind of 30 and 2 approach, or, potentially asynchronous breaths and ventilation, depending on kind of what protocols you're working under. And it's one of these things where in medicine, I think there's still like kind of a lot of controversy about it. And I, kind of specialize in wilderness medicine, and I have a lot of colleagues who focus in particular in wilderness medicine on drowning, because that's kind of a wilderness outdoor etiology. And, you can get some pretty good debates going around the bourbon table at wilderness medicine conferences about some of this stuff. So I think it's safe. So zooming out from that a little bit, I think it's safe to say that you do need to be thinking about oxygenation and ventilation much earlier in the sequence than we conventionally would. I think in many traditional cardiac arrest management situations now, we're not even necessarily thinking about trying to do any of that stuff until maybe a cycle of CPR or two, as far as, like placing biads or intubating or anything along those lines. And the emphasis really is on, like really high quality chest compressions, rhythm analysis and timely defibrillation, kind of early on. But we gotta just remember that, hypoxia was a much larger direct contributor to this cardiac arrest. So I'd be thinking about, going ahead and trying to do, probably some, high flow oxygenation strategies, maybe even some flush rate kind of strategies if I had the equipment with, some underlying devices, and just making sure that airway is patent, and doing what I need to do to, integrate that early. So what's kind of interesting about this is if you've been in the game for a while, it's almost like you just have to sort of say, oh, well, we're just going to like revert to like 2015 guidelines and just kind of hit that airway, early on as part of our sequence. Yeah. So that's what I'm thinking.
And that was exactly what I was going to say. Was I'm going to run this like it was 2005, and I'm going to do ABC, because we know in this point, or at least we're pretty sure that he probably had some sort of asphyxiation event. So I'm going to try to fix that asphyxia pretty hardcore. Yeah, you do some chest compressions, but in this case, this problem still is that he didn't have oxygenated blood. So
yeah, I guess it's more like the 2010 guidelines. Now that you say that, I sometimes lose track of all the changes.
Yeah, I'm trying to remember when I took an ACLS class the first time.
Yeah, right.
And
yeah, I think the change probably was actually the 2015 guidelines that kind of focused us on circulation, more so than anything else in so it's really just like I said, like the way that probably a few people, I don't actually recognize too many names on here. I don't know who's behind some of the fire department logins, but there's probably a lot of people on here who've been kind of working codes for a long time. And for those of us who have been doing that, it was kind of like a little bit of a big mental change when we started getting taught airway is not that important, initially. So that makes it actually kind of easy to just say, oh, I can just kind of flick, the time machine in my brain, and I can just do it kind of like I was initially taught.
Yeah. All right. Quick question. Are you putting a seat collar on this person, on any of these three people up front?
Not up front. No.
Cool. Me neither. And we just talked a little bit about these things. By the way, the chance of C-spine injury in actual drowning victims, super, super, super low, interestingly enough. Like, unless you see the person dive into the shallow pond, chance of a C-spine injury is actually like on the thousandths of a percent or something like that. Really, really low. So
I would also just like to point out that there is no specifically known benefit of rigid C collars, and they are likely to interfere with many of the other things that we need to do in this code management that are associated with better outcomes.
Agreed. I'm going to skip the epi one because it's kind of a questionable topic, but you could give it. And then we talked before about the shock. Does the electrocution part, in addition to the drowning, change a whole lot? In my opinion, probably not for us. We're still going to do the resuscitation. You're still going to, you have the layer of complexity in there where something else may be going on, but I don't think it changes much in terms of my management. Any change it for you at all?
No, I don't really think it changes anything, other than I want to realize that if we can do really high quality code management, and we can be really timely in our defibrillations, then if it is an electrical cause of the cardiac arrest, sort of chiefly, we can have some pretty good outcomes with that. We can really like get them back. This is not a situation where, it's a lot different situation than, finding your dude on the floor of his living room with an unknown downtime and an unknown cause. So we just got to pay really close attention to sort of being crisp in our high performance CPR.
Agreed. Now, let's say as we're, luckily we're getting towards the end, but say you get ROSC on one of your patients, which I believe was the first guy in the water. I think that actually happened. And he's being transported. You've called for a helicopter and you get a HEMS crew that's arrived. You still have 2 patients under active CPR. You're now notified of another patient, a fall 60 feet from a ride at the other end of the park. So we're down again, kind of here. Where'd it go? You can't see. There it is. We're down here. It's up there, about 300 yards between us. And you, other than the HEMS crew, are the only medic. Everybody else is BLS. Who's going to do what now? Are you going to stay with these guys? Are you going to send an EMT to triage? Where are you thinking? Who's going to do what at this point? What's your thought?
So my first thought is just like never go on spinning rides. This is just like basic life skills. I don't know why people do this. The faster they're spinning, the more dangerous it is. You might as well just, play Russian roulette, put that gun straight to your head. So I'm not into victim blaming, but as I'm running over there, I would just be thinking to myself, alcohol, no alcohol, underlying condition that made her more susceptible to maybe like passing out under centrifugal force or something like that. I don't know, but like who gets on this ride in the first place? So after I deal with those emotions and I arrive on the scene,
after you completely judge this person,
yeah,
and to determine that it was definitely their fault one way or the other.
After I tell myself I'm not judging my patients while I judge my patients, so that I can continue to live in my own head. Okay. So backing up a little bit. So we have these 3 cardiac arrest patients. One of them got ROSC. There is post-ROSC management that does require potentially a little bit of finesse, pressors and good, ventilatory skills and, intubation potentially and some things of that nature. So, you're going to have somebody who you don't want your novice, stand around with that post-ROSC patient. That's for sure. So that's something you need to consider. It's worth probably kind of considering experience and skill sets and possibly even scope of practice issues. I think that certainly BLS post-ROSC is a thing. Certainly many BLS providers out there are, experiencing that in doing good timely care, but that really is at that point something where it's one of these things where actually like the paramedic skill set can potentially make a huge difference as far as like, pressure support and some of the things I just mentioned. So I'd probably want a ALS provider sticking around with that post-ROSC patient. So it may be appropriate to take a BLS provider and sort of send them ahead as a scout and let them do what EMTs do, which is assess the scene, provide initial, life-saving measures and get that airway open if it needs to be open and stop the bleeding if they're bleeding and, let EMTs be EMTs. And if when they get there, they say, yeah, this is a big deal and we need, ALS care, then we can, remanage our resources from that point. So, I'd say from a triage standpoint as well, the patient who has ROSC probably wants to go ahead and get on that helicopter, probably should go ahead and get on that helicopter and kind of get flown out. So that's what I'm thinking.
Take it. All right. Well, despite your objections, the HEMS crews decide they're going to take the other 2 patients, and the ROSC patient ends up in an ambulance and goes to a non-tertiary care center, essentially, just a kind of bigger size community hospital.
Sure.
But you are then tasked with this last patient here. You go through like a March algorithm. You've gone back. You went ahead and sent your EMT, who reports that the patient has no massive hemorrhage. They've got sonorous respirations and kind of shallow breathing. Their SAT's not good. They don't have a good pulse in their flexor posturing. So this is a person that seems to be in pretty good distress. She's got an obvious head injury. She's getting shocky. Some specific questions, because we're going to do the basic trauma management stuff, and we've gone over that before to some extent. Some specific targeted questions in this trauma patient. Are you giving her IV fluid with a BP of 94 systolic?
No.
Okay. Are you placing a pelvic binder on this person?
Yes.
I am too. I think absolutely. You know, I feel like the pelvic binder is so uncommonly used that we've just kind of forgotten it's there for the most part. But
The pelvic
all
binder is one of my favorite tools in the world.
Passionate about it.
I am. It's like, it's
yeah.
so simple. It's so elegant. It has a very high mortality benefit and basically no risk. I mean, it's like probably one of the few things in medicine where you can literally put it on almost anybody. I mean, there's some like very weird, like one-off types of pelvic fractures where some literature has said that if you put a pelvic binder on, it'll like, cause like that kind of a thing to happen and you'll screw them up. But that, there's like so rare and just so specific that you can literally just put a pelvic binder on yourself right now and it doesn't hurt. It doesn't make anything worse. It's not going to make anything worse. But if you have a pelvic fracture, it is associated with much higher survival. So we should just be doing it commonly. And honestly, commercial pelvic binders are too expensive. We should be using them a lot and they should be kind of much more, affordable and kind of much more disposable. So considering how much we should be using them, I think it's uncool that they cost like $100 a pop for a commercial one.
Fair statement. Yeah. I think anybody that's shocky and can't tell me that their pelvis doesn't hurt should probably get a pelvic binder, among other people.
Well, yeah, I should point out too, I'm not talking about like literally putting on anybody just like, but serious mechanisms of falls, especially from height.
Yeah. That was my assumption too. Yeah. All right. Say that she arrests and, at that point, we're probably going to give her some fluid per trauma arrest protocol. We're probably going to decompress both sides of her chest, even if we think she's got breath sounds, but she just had a big fall. So there's a good chance she might have an interthoracic injury or tension pneumothorax, developing tension pneumothorax. We're going to make sure airway is controlled. Now, most trauma protocol, or many trauma protocols, some trauma protocols, I should say, are going to say, don't give epi. Epi and trauma just makes them bleed harder and makes things worse. Let me ask you the question, and there's obviously a point to this. Are you going to give epi to this person? What's your thought on this particular arrest? Fall 60 feet onto her head. What do you think?
Yeah, so this is an area where I need to probably brush up on knowledge and literature and so forth. My thinking is that epi is not going to be my like a first line consideration. But at a certain point, you need to basically restore vascular tone. And we don't want to be giving large amounts of fluid. So we all should basically know that about trauma patients. So we need to sustain MAP, and we certainly need to sustain cerebral perfusion. And there's only so much fluid that we can really give before we start causing damage from that fluid. So, I think that if you had other better pressors, then they would be better. But just in my own practice alone here in Kentucky, the only thing that I have available is epi. So if I need to maintain perfusion after giving probably a pretty small fluid bolus in the grand scheme of things to maybe just sort of, get some vascularity kind of open, I'd probably be considering giving epi for that purpose. And I think that with the epi, it's a little bit sort of like the idea of, oxygen for a STEMI patient or a stroke patient or something like that, where, we probably are going to be doing maybe a little bit of damage, but we also still have to address some issues. So we want to probably be a little bit cautious with it and judicious with it. But if your heart attack patient is hypoxic, they need oxygen, even though we know that's going to cause, a little bit of reperfusion kinds of damage and stuff like that. And so that's my current understanding of epi and trauma, is that if it's all you have is a pressor and you need to provide perfusion to your patient, then it is something that you should be thinking about using. but we'd probably be better off, our patients would be better off if we had other pressors to choose from. And hopefully that's correct.
Yeah, I will say that I'm probably going to give epi to this person just as a, true that epi in the bleeding patient probably doesn't really help anything. It may make things a little bit worse, and in most cases of cardiac arrest, probably not. But if there's a significant head trauma, and if it all seems to be head, essentially, or if it seems to be as a result of a high like cervical spine injury or something like that, I might consider giving a dose or two of epi to these folks. Only because when you clock your head, when you have a bad TBI or when you have a bad spinal injury, then you do lose tone in your blood vessels beneath essentially that level. And we've seen folks come back with a couple of, not epi every 3 minutes times 6 doses, but like 1 or 2 doses of epi as a trial after you've done everything else, cleared their chest, given them fluid, put on the pelvic binder, controlled their airway, all that kind of stuff. A dose or 2 of epi in a bad cardiac arrest caused by what seems to be a head injury, and she may have other injuries, but caused by a head injury may give you enough tone to get ROSC. Has been my personal experience. So I'm kind of let's not prioritize it, but let's give it a little bit later. And if you have a question about that, I think a great consideration is to call medical control about this and say, hey man, I got X, Y, and Z. You want me to give her a dose of epi, or you just want to say we've done our part, or what? So, well, cool. I'm gonna skip this last question because it wasn't worded very well, but basically it was about dispositions and that sort of thing, which brings us to the end of this. So, David, thank you very much. I think another patient survives, or probably don't, because I'm not sure that these were survivable injuries to start with for the most part. But it's good to think about because there's always the next person, and maybe we don't get this one, but the next trauma arrest that comes around, you get back, and then the guy, goes off and gets a job, and everything's cool. Starts paying taxes again and funds your big government EMS offices, I suppose.
Don't know why we had to make this political. I was just going to say that anybody who's interested in completing a degree in EMS online and getting many credits for your existing paramedic certification and merit badges should please feel free to contact me at david.pfeford@eku.edu so we can get you enrolled today.
You too can support big education.
You too can support greater opportunities for paramedics, which will come from higher education attainment. And if you believed anything that I told you about patient care and mass casualty management this morning, there's no reason you shouldn't believe me in making that statement.
Fair enough. I'm just kidding. All right. Thanks again to David Pfeiffer from EKU. Always a pleasure to talk to you, sir. And for everybody else out there, emsgrandrounds.org/UCEMSConEd, or at this